So our very first brainwave. So we're very excited and we're so happy that everyone was able to come. So my timer so I don't go over because now I've made everybody late. My name is Diana de Carvalho. I am an associate professor in the Faculty of Medicine. And today I want to talk to you about movement, pain, and posture, and the relationship between movement, pain, and posture. So I'm going to talk about two ways that my research group has been approaching this complex intersection. And I'm going to share with you some ideas and maybe challenge some ideas or preconceived notions you might already have about how these three factors are related. So first, I want to introduce you to my laboratory, and this is the Spine Lab, or the Spine Biomechanics and Interventional Ergonomics Laboratory. We're located right here in the Health Sciences Center, just up on the 5th floor. So this is a comprehensive biomechanics lab where we have all the tools to measure movement and posture and pain, and we can do that in a highly controlled and specialized manner. And we're experts in the low back. And specifically, we're really, a lot of the work that we do in the lab is looking at understanding how sitting for long periods of time might be affecting our back function and perceived pain. Anybody have pain when they sit for long periods of time? Yeah, it's why we study it. It's a thing. We're also really interested in movement and pain and how that relates, as well as the interventional part of the tagline there is looking at some of the strategies and interventions that might be helpful for folks who have to sit a lot and have pain when they do sit. So this is not very responsive. Thank you. So as I mentioned, we have lots of tools. So when we're looking at body function, or muscle function is a big part of that. So we have the ability to look at muscle signals from the core, so the front and the back of our torsos. And we can do that both for the superficial muscles, the ones right under the skin, or we can drop electrodes and get to some of the deeper ones, the deeper anatomy lower down. We're interested in how the forces of gravity, for example, interact with someone when they're in a static posture. So we might look at spine height as a surrogate measure for compression. When we don't move a lot, we get fluid that leaves our spine. We become shorter throughout the day, and we can use that as a good outcome measure of compression that's happening in the disc. We have, like I mentioned, the ability to measure posture and movement with a great deal of accuracy. We do that with motion capture cameras, similar to the technology that you are familiar with for video games and for movies. And so we can use that to measure joint angles, posture in space for a number of different tasks. I mentioned sitting, but we look at a number of different functional tasks as well as occupational tasks. And then we can combine that with our understanding of forces, either measuring at a seat interface through a pressure mat, for example, or at the floor with a ground reaction force. And we can combine those together and estimate joint loading of whatever joint of interest. And again, mine just happens to be the low back. And then I'm most pleased that we have a lot of tools in the lab to help train our students in some more specific anatomy of the spine. It's a pretty complicated area. Neuroanatomy and biomechanics, so that we can train our next best and brightest. So I mentioned biomechanics. I'm actually a biomechanics researcher. And what is biomechanics? So biomechanics is the study of human motion and the forces that cause that motion, or the forces that are resulting from that motion. So throwing a ball, catching a ball, that kind of idea, the forces that are involved in that, contact forces. But we all know who's really driving the show, right? Because that's why we're here. It's Brainwave Conference. And we know that anything that our body is doing, motion or posture-wise, that signal or that control comes from the nervous system, either up in our brain or at the level of the spinal cord. So everything that we see, that I look at from a biomechanics point of view, so we're interested in the physics of motion and all that jazz, you can't look at that without understanding and also appreciating what the nervous system is doing, right? So brain controlling motion, we've heard that a few times already today. But we also know that our signals don't just come down because we are very complex. We have complex motion. We do lots of complicated things. And if it was only a top-down approach, we wouldn't have a way to react or change to our environment depending on what is going on around us. So we have information that goes back up to our brain to have, to give that control system some input in terms of what's going on around them. And we have all of our senses from auditory, touch, visual systems, giving that information back to the nervous system to maybe do something about it. One of the senses that we're really interested in, obviously in our lab, is pain. So what is pain? Because pain is an important signal that our brain uses in terms of interacting with the environment, but it's a complicated concept for a lot of people really to understand what it is. And I'm going to tell you why it's so complicated. So pain isn't really pain down where we sense it. So we start with nociception, or a noxious stimuli. What is that? Well, it's a harm signal that is sensed at the periphery of the body or somewhere out in the skin. And an example of a harm signal could be a temperature that's either too hot or too cold, something mechanical that's too sharp, or a break in the skin, for example, chemical that could burn, for example, the skin and cause damage. So it's a signal that may or may not carry information about harm, because we know it could, just be a little bit of a warning, or it could be something that's a bit more serious. And that information goes up to the brain, also could be modulated the spinal cord, but it goes mainly up to the brain. And there is where the magic happens. That's where pain is perceived. When it gets up to the higher centers of the brain, it doesn't just go to a nice little tight pain area per se. There's a lot of interactions that happen with that information in a number of different centers of the brain, like emotion or your memory or something you've learned about that. And it's that complex interaction that's happening about the signal that came up that makes pain so complicated. Because pain, for me and how I'm perceiving it, is going to be different from somebody else because of the way there's so many different ways I can interact. And it even can be different for me depending on my emotional state. So you can get a sense of how complicated it can be. But it's an important signal because a lot of times, especially if you've dealt with patients or yourself, if you've experienced pain, it's a really big signal that's very hard for your brain to ignore. In my lab, we're really interested in low back pain, and low back pain is a pretty common condition. Does anybody, I hate to ask, but does anybody have low back pain? Reoccurring? Unfortunately, and it's common. Most people will experience back pain at some point, and it's really it can really have a profound impact on a person and how they interact in society. I don't know if you've ever hurt your back before. Maybe you don't have back pain per se, but you hurt yourself. It really is scary. The first time I experienced it, I was like scared to move. I'm like, oh my, this is really serious. Like, it's a big thing that you pay attention to. And part of that, how big it is and the input you get there, it impacts then how you respond to it. So you might start changing your behavior because of that. You might move differently, a bit more cautious. You might not move as much. You might feel like you need to just lie down, curl up into a ball and not move because you feel like it's going to harm you. Because remember, I talked about nociception being a harm signal. So it's an automatic. It's easy to jump to, okay, I'm hurt. I've been harmed. I need to do something about it. And it's that change of behavior and the way that we start to change perhaps how we move or how we hold ourselves that then can have a cascading effect. And it's part of why low back pain as a clinical condition is so difficult to treat and manage. It has a very high recurrence rate. Once you've had an episode, you're at high risk of having repeated episodes over your lifetime. And by the time someone's hurt themselves and they go in to see somebody about it, a whole host of things could have happened, and kind of it snowballs. And what you end up here, it could have been very different from what it was in the beginning. And so that's where it's a very, very complicated condition to treat. It's also something that is aggravated by sitting. So if you have if you have back pain, if you're currently in back pain, sitting most likely will aggravate it. It'll make it worse. And that's a pretty common safe assumption to make. But what is really interesting is, because I mentioned that we study sitting in the lab, and just to jump back a little bit, so we know that sitting, it kind of makes sense that sitting would hurt or aggravate pain, right? Because you're bent over, you're hunched, you're flexed, you're squishing stuff. It makes sense, and the biomechanist in me likes that. Like, yeah, you're pushing, you're pulling on stuff. Okay, it makes sense that you're going to irritate and have that hurt. And you probably remember somebody at some point in your life telling you, sit up, have nice posture, you're going to hurt yourself. But what's really interesting is, and this is what I want to challenge you on, is it's not necessarily posture all the time. And so some of the studies we've done in our lab don't just look at the low back pain patient per se, because they're very complicated. I already told you that. It's kind of hard to do a controlled study with them. So when we look at healthy young individuals who don't have back pain, I want to share with you what we see in terms of pain. So usually we are measuring, their back angles, muscle activity, all the mechanics to get a picture of posture and movement and all that stuff. And we follow them in terms of they sit maybe for 2 hours, and we want to know how they're feeling, if they have any pain. And so what you're seeing here is pain data on the up and down axis. We have it going from 0, which would be no pain, to 100, which would be the worst pain imaginable, and across time. And you can see here, I have 2 lines. I have 2 representative lines from real people who have reported their pain. And this is what we found. Some people have very high pain responses to sitting, and they're not a back pain patient, but sitting will bring on this response. And it's high enough that we would consider it clinically important to pay attention to. It's not just annoying. And other people, represented by the green line, don't have that pain response. And this is really interesting to me, because you would think that the red line people are probably sitting worse and the green line people aren't, right? In a healthy, they don't have back pain already. There has to be something causing this. And the really interesting thing is, we did a large study, and there's been several studies by many of my colleagues and in different places who've looked at sitting biomechanics, so their angles and how they're sitting, how they're moving, and this pain response, and we found that it's not matching. We did a very large study where we brought in people from the general public, some people that actually had a history of back pain, people who didn't have back pain, and we ran this protocol expecting to see that the people with the history and the people that sit poorer or have more flexion would be our pain group, but they weren't at all. There was no differences between how people were sitting, their posture, and what that pain response was, which was really surprising to me, and it might be surprising to you too. What does that mean? Well, it might mean that all these ergonomic interventions that we have, that we kind of throw at people, might really only be relevant or important for some people versus all of them. And so that's kind of an important thing to know, right? But we're still trying to understand what this pain is. Is it just because we're asking them to give us our pain? We don't think so, because we did a large systematic review, and it's consistent enough in the literature that this is a real thing, but we want to understand what it is. So right now we have a really large study that's going on. Put your hand up, Allison. Allison's over there. And she has some recruitment posters down on the desk. So if you're interested in participating, just pick one up and let her know. But we're trying to understand what it is. So we have a study that we're collecting right now where we're measuring brain waves to see are these people just more sensitive to pain? And we're looking at blood biomarkers to say, okay, are we also seeing our markers of pain and inflammation objectively there versus the subjective measures of people's perceived pain when we're asking them? So that's going to help us just kind of validate too that this is a real thing that we're seeing in these sitting pain groups, but then also try to understand, okay, what is it? Are people more sensitive, etc. We've also been following a cohort of people to look at maybe this pain group is just an early clinical indicator of a future case. So we are coming to the end of that study as well to try to understand what it is. And then finally, pain and movement, right? And this is where apparently we can learn a lot from neuroscience from a chicken. According to Dr. Powers, so had this in here. So it's a chicken or egg. I already said that. So when you have pain, you might move differently, and vice versa. We do know that some movements can be injurious and cause pain, but to tease it out becomes really difficult. And so my PhD student, Mona Frey, is just come to the end of a very large study where we brought people into the lab, two groups, back pain patients who have episodic pain and a healthy group. And our back pain patients come in both when they're in an episode and out. And the healthy people come in and they are either induced with pain using a lab model of pain by using capsaicin cream or out. And we're looking at their function. So we're looking at a number of functional tests like sit to stand, flexion, a reflex test, so how the muscles turn on, endurance of the torso, to try to understand, we can get certain information from our back pain cohort, and we're going to get different information from the healthy cohort because of, again, the complex interaction. So we're hoping that we can start to tease away a bit of that chicken or egg. So my main takeaway for you is to question, if you're thinking next time someone says sit up, it's not necessarily posture, at least in sitting for pain. And again, we really don't have the answer in terms of what comes first, pain or altered movement or vice versa. And maybe it doesn't matter. That's a question for another day. My email address is up there on the QR code. I'm happy to chat with you in the future, and I'm looking forward to our panel discussion. And just want to give a quick shout out to all my amazing students. I have the best students in the world. I know every supervisor says that, but I really do. A lot of this work has been because of their hard work and tireless hours in the lab. So just to thank them and our funding sources. Thank you very much.